Tillman's Body Talk. This is Mike Tillman here, Dr. Tillman. I'm here with Nikki Torres, and Nikki is in PTA school, and we're just gonna have a conversation on, do I need surgery?
Well, usually the average person sees a doctor and the doctor immediately suggests surgery, but I would look at surgery as like a last resort. I mean, if it's not an emergency, definitely like, let's see what else we can do before we throw you in under the knife.
Correct. So let's go over head to toe different surgeries, right? Neck surgery, right? You got fusions, you got disectomies, and I would say, you know, if you ask me, most of those surgeries don't need to be done because most people will rehab. Understand, if you do an MRI, you will find something. It's like saying I'm going to find a gray hair or a wrinkle. I don't need an MRI when I treat you. What I want to know is how you respond. If you came to me with an MRI that said you had 4 herniations, I'm not going to say go get surgery. I'm going to say, hey, let's try these exercises. If I can get you pain-free and full motion, you don't need surgery. And worst case, I'm wrong. You're going to have the same surgery you wanted or they wanted to do. But if I'm right, I save you a lot of time and money. You learn how to sit, and you learn what to do, so you're not getting a second surgery or a third surgery.
I learned how to help myself.
Let's talk about shoulder surgery. Let's say you come and you say, Mike, my shoulder hurts right here.
I'm pretty sure I did come to you when I met you, and I said, hey, I'm pretty sure I tore something in my shoulder. I'll see you later, kind of thing.
Exactly, and what I know is 47% of shoulder comes from the neck, so I have to clear the neck. Now, what typically happens is they'll take this patient and they'll send them to an orthopedic shoulder who typically doesn't clear the neck, because what they want typically is MRI right away. And what I'm trying to do is, hey, I'm weak, or there's a certain motion in my shoulder that hurts. If I do different neck motions, can I change that without even moving the shoulder? And that happens close to 50% of the time. So I don't see how it's not more ruled out or even looked at. Mm-hmm. This is why I'm out there marketing, like, to let me see you first. Yes. Let me clear the neck so you're not having a surgery. One of my biggest complaints is, oh, I have a rotator cuff tear, I have a full rotator cuff tear, what can you do? And we fix those all day without surgery, and what they don't understand is, what does a full rotator cuff tear mean? Does that mean just 50% over? And how does that compared to just a normal rotator cuff at that age? So if you're 70, I expect you to have a rotator cuff tear because you're worn out, and all of a sudden it's like a shoestring, right? Mm-hmm. And that's why even the executive board of physical therapy says, hey, if you're over 50 and you have a rotator cuff tear, you have a 75% chance of getting you better just with PT. Because typically surgery, what they're gonna do is they're gonna take that shoestring and put another shoestring in it. And then we gotta strengthen it and all the stuff we would have done before surgery to see if you would have got better just with therapy.
So the rehab is actually the prehab?
Correct. One of the reasons that I have my own clinic is I have to have the right to stand up for the patient, or to even disagree with the surgeon and say, no, you know, you have a full rotator cuff tear, but we've gotten you 90% better in 2 weeks.
Look at the facts.
Yeah,
right. And I think that's really hard for patients. The pain is what's speaking to them, and you know, if you're not used to pain in these areas, you're like, oh, something's broken, it's wrong, it's got to be fixed. Plus that instant gratification that everybody wants. But a little bit of physical therapy can go a long way.
Correct, and she brought up a good point, is they're so worried about the pain. In my job is sometimes to push through that pain to get you to that pain-free place you want to. And that's where the patient gets stuck, is they don't know what pain to push through and what pain to not push through. And that's what I do, is you come to me and I test you with different motions, and I'm gonna say, hey, this is a great motion. When we do this stretch, even though it hurts, you come out with more motion, right? And you're stronger. And if we did that for 2 or 3 days, guess what? Your pain starts going down. And so I like it. It's like a puzzle, and I love challenging that, because every patient is different. And how do patients, you know, buy into my philosophy? Well, I prove my point. When they come in, I test it, and they're weak, and then I do this exercise, and they get stronger, and all of a sudden, you know, what they're worried about gets a lot less significant. Let's do elbow, forearm pain. I want to say the Expo study in September said that about 70-80% it's coming from the neck, especially if it's radiating. Understand that shoulder pain doesn't radiate. Elbow pain shouldn't shoot down typically. And so if you see radiating pain, that screams neck to me, you know.
That good old brachial plexus.
Correct.
So
Yeah.
all the nerves,
Yeah.
all the way into your hand, all root from right up in the neck.
Yeah. And tricep weakness, when we test and someone makes a fist, we tell them to push down and we break them easy, that screams neck, right? That's typically not shoulder. And so these are the cues that we look at. A good therapist spends a lot of time questioning, and they almost know the answer before they test just by good questions. And these are not answers I get from an MRI. Most of the time when someone gets me an MRI and say, hey, do you want to see the pictures? I'm like, no, I really don't, because I want to know how it behaves. I don't want to know so much what it is. I want to know if I can change it, if I can get the motion better, the pain to go down, to get you stronger, those kind of things. You know, so let's go. We went neck pain. Thoracic pain you don't see as often. It's more common in women, typically because they're shorter, and when they sit, you see older women don't fit in chairs, and that's why you see that rounded back. Plus, they have a weight in the front that constantly pulls them back along with the head, and that, you know, that pain in here as they get older gets pretty significant. You know, and I don't know a lot of surgeries in thoracic, which is a good thing.
Yeah.
But I guarantee you most people don't know how to extend their thoracic. You want to demonstrate that real quick? Just
Thoracic extension?
yeah.
Without
Just,
a back of the
yeah,
chair?
just elbows in and go up, 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 up. And this is a great stretch that I wish everyone in the world would do, because it really helps free up your mid-back, right? All right, and then what about low back? Low back pain.
It's like the number one.
Yes, why?
Posture.
Exactly.
What you do every day is usually what causes the pain there.
And then how do you treat it? What do you do all day?
The opposite of what you do all day.
Exactly. And that's why bending back is such a key. That's why we like press ups. That's why, you know, again,
So every day, most people live a sedentary lifestyle or work at a desk in an office, and they're like this.
yeah.
Or
It's pressure over time. So you see more herniations every decade, is what you see. And so typically, you know, I'm estimating, but it's 40% of 40-year-olds, 50% of 50-year-olds, because it's slowly aging. So it doesn't bother me when someone's bone on bone, 100% bone on bone. Because I have people that are 100% bone on bone and don't have any pain.
that scares people
Yes.
when they hear that.
Yes.
Bone on bone? Wait,
Yeah.
you mean my discs are gone?
Yes.
It's terrifying.
I know.
I remember the first time, I was 26, 27, when a doctor told me, mentioned something was wrong with my discs. And I just thought it was the end of the world.
Yeah. And you know, right, you know, what they do, it typically is they get an MRI and they kind of constantly tell you what's wrong with you, instead of this is why it happened and how are we going to change those habits so that it doesn't continue to get
We
bad.
fix it.
Correct.
Right, and that's not what they say.
Think about bones, right? If I'm a sloucher, neutral is neutral, sitting up is neutral. If I'm leaning forward and I'm resting on the front and I'm slouching, which I do a lot, and I'm always on the same part of the bone, am I not going to wear that out faster? Am I not going to have more herniations over time? And if I get surgery to take the disc out and I continue to live like that, it's just going to go to the disc above or below because you didn't learn anything.
Right.
So this is why I'm a big advocate of PT, even if you need surgery, because you've learned so much, and that's the key, you know. So let's keep going. Hip surgery, right? You hear labral surgery, you hear bone-on-bone hips, total hips. Those scare me because I know that 70% of hip pain is low back, right?
Mm-hmm.
Two, it's more even now, but when I first came out 20 years ago, I would say, you know, 60 to 70, the majority of hip replacements were women, right? And why? Because we teach them to sit with their legs crossed, closed. Yeah, and
What
they
about
get.
this hip baby carry?
Yeah.
And who knows what else?
And what happens is, as a woman gets older, they start walking with their feet closer and closer, so they lose balance, and the hip hurts. The IT band's real tight, so it pushes the bone. It wears out faster. And I can tell just by watching how a woman walks or how she stands. If she stands and her feet are that close together, she's at a higher risk for fall. I know she's gonna have IT band pain. It doesn't matter how much she stretches, she continues to stand with her feet close together. So what's gonna happen if she does get surgery is she's gonna live the same, and then they'll wear out the other hip, and then they'll replace both. And that's the other thing with surgery is people think it's a fix-all. And what they don't understand is sometimes they do surgery and they're happy with like, hey, this is 70% of the motion you once had, but it's not as painful, but you don't have so much motion. Total knees are a great example.
It's better, but it's not the same.
Correct. Total knee is a big one, right? You know, total knee, they go, think about this. For a total knee, for me to say you need a total knee, you have to have bone on bone, which happens after what age, right? And knee pain, and that's it. And typically I would say most total knees don't need to be done if you can get motion, if you can lock the knee with weight on it. You see all these people stand, these older people stand with bent knees and they have terrible knee pain. And of course they're bone on bone, but if we get that knee straight, then the quad can work. And then you have to ask yourself, well, now you're 100% bone on bone. I got your motion, you don't hurt, you can use your muscle. Do you need a total knee? No, right? The ones that do get a total knee, what they don't understand is they don't typically get the full motion, right? A total knee surgeon is typically happy with 110 degrees flexion. And the biggest complaint I hear is I used to be able to bend my knee a lot more, but the surgeon's happy, but I can't sit low, you know, I can't bend it. And
daily functions become harder to do than before surgery.
Correct, yeah.
Well, what about the longevity of a knee, total knee? Like how long do they last before you have to get that same knee redone?
Yeah, well, they last long, but there's so many things that can happen. One, people change the way they walk. They're supposed to walk with a toe out and they start walking straight. Two, sometimes, you know, a surgeon will put the wrong size in or measure wrong. And so I've seen total knees come out and, you know, the knee's all off, the angle's off, it's totally crooked, it is not good. Or they put the wrong size kneecap in. And so everyone thinks like, oh, it's gonna fix, it's gonna be great. And it's not always the case. So one of the reasons I still push like, hey, try PT first. If we're wrong, guess what? You can have the surgery. But if we're right, we save you so much pain, so much heartache. Even if you have a good outcome, what have you learned? And that's the big thing. I do know some great surgeons out there, you know, but my job is to use it as a last resort, where if I'm a surgeon and you're coming to me for help, I got two ways to help you. I can inject you or I can cut you, and you're begging for help. What am I gonna do? You know, that's a hard scenario, so I can't, it's hard for me to get after the orthopedic surgeons too, because you're coming in begging for help.
Instant relief, I need it now, give it to me.
Exactly.
Yeah.
And that's what you see too, is people, let's say it takes me 2 or 3 months to get you better and prevent a surgery. People think surgery is an instant gratification. They don't understand that it's still 2 or 3 months of rehab. And is it 100%, or are you 70% still in pain? Those kind of things.
Yeah.
So, let's go just a little bit lower. Ankle, right? Ankle's a hard one. You don't see tons of ankle surgeries, you know, but you do see, what do you think about orthotics?
Inserts in the shoes?
Yeah.
I think they're necessary for certain footwear.
Correct. They should be a short-term solution if you're overloading or you have inflammation of the tendon. But your whole goal, you should be able to walk around barefoot, right? If I can't walk in my house barefoot and I have to put these shoes on with orthotics, is it because I'm not flexible and the orthotics or the shoes allow me not to be flexible so I can walk without pain, but it's not functional, right? You should be able to run and grasp barefoot. And what I see people do when they get orthotics is then they become so dependent they can't walk without them, and then they hurt without them. And it should be something like an ankle brace that you wear temporary and you get flexible. Now there's always the cases that someone just has you know, a malformed foot, or the special cases, but it shouldn't be that 80% of your patients have orthotics, you know. And I think there's studies out there where they did ones where they measured precisely and they they had the other patients just put their foot and mess it up, and there was no difference, you know. And so it doesn't have to be that specific. So you know, you can go to Academy and buy Spinco arch supports and just keep trying different arch supports to see if that helps you. But again, your whole goal is to eventually get off that. Now, the problem with a lot of people when they run is they don't understand impact, right? I cringe every time I see someone run on the sidewalk, right? Because they don't understand physics, right? They don't understand that there's no give. And so when they run on the sidewalk,
the earth just gives it right back to you.
Correct.
Right through the ankle and the knee, into the hip, into the low back.
Do the water test. Pour water on the sidewalk, and it doesn't go anywhere, right? You pour it on the street, and you can see it go until all the little cracks, because it absorbs a little bit, right? So no sidewalk. Street is a better running surface, but pour water on grass and it just soaks in. It's got a better absorption. And so when I get these older patients that run for life on sidewalk, they are terribly vulnerable. They just have tremendous amount of pain because they're always running on sidewalk. I just don't think they think about it.
Yeah.
They're trying to be fit, and so that's something that isn't talked about enough. The reason why we're even talking about surgeries is we just want you to think about it. We want you to have just a little bit of video to think about your answers. You can always shoot me an email with questions. I've done a lot of videos, but it's hard for me because every time someone has a surgery, I'm like, man, could I have prevented it? Two, what did they learn even if they came out pain-free? And is that gonna lead to another surgery? Is the total knee gonna lead to a back surgery because they changed the way they walk? There's so many different elements in there. And so I always wanna see the patient before, even if they need surgery, because then it's such good information to see how they functioned before, to know, one, what can I get them back to, and hey, no, you didn't walk like that before surgery, those kind of things. But we challenge you definitely to try PT first, always, and understand this is the hard part from a patient's perspective. If you go to 10 different therapists, you're gonna get treated 8 different ways. And so understand there's different kinds of therapists out there. There's some that do manual. I'm a McKinsey sports therapist. And so if one doesn't work for you, I would actually say try a different type of therapist. And then if that doesn't work for you, then by all means, if you need surgery, you need surgery. But I just wanted you to think a little bit about it and make an informed decision.